All right, so hello everybody. A very good morning, good afternoon, and good evening to all of you who are here. It has been really heartbreaking to see India, Pakistan, and Nepal go through COVID-19 crisis in the last 2 months. We do salute the entire medical fraternity in all these regions for their tireless efforts and are glad that finally the new cases have started to decrease. On behalf of ANIO, we do extend all our prayers, positive thoughts, and best wishes to everybody out there in South Asia. Next slide. So just going over a few housekeeping tips, we would like all of you to keep your videos on to keep the meeting interactive. I would suggest that you please have your audios muted so there's no background noise. And any questions or comments would be taken via chat, so you can chat us while the webinar is going on. Next slide. And on behalf of ANIO's executive committee and governing body, I would like to welcome you all for today's special webinar. And before starting the webinar, I would just like to pass along to Dr. Amit Govil to thank the sponsors.
Okay, just want to give a special thanks to our sponsors for an unrestricted grant. They make things easier for any organization to put these things together and for other purposes that will help us with the mission of ANIO. So the 4 sponsors, I want to thank are Natera, Veloxis Pharmaceutical, Bayer Pharmaceutical, and Chinook Therapeutics. Just a few words about these companies. Next. So Natera, which is the Prospera transplant assessment test, a cell-free DNA test, and Renasight, which is a kidney gene panel. Next slide. And Prospera test helps patients thrive and prosper, and it offers more precise solutions for post-transplant rejection assessment, while Renasight kidney gene panel is a comprehensive, convenient, and accessible genetic testing and next generation sequencing on 380 plus genes linked to kidney disease. Next. Veloxis Pharmaceutical, which produces Envarsus XR, which is extended release tacrolimus. Next slide. And their mission is transplantation is our life work, and it's a specialty pharmaceutical company committed to improve the lives of transplant patients. Next slide. Bayer Pharmaceutical, next slide. Headquartered in New Jersey, headed by Sebastian Goethe, has multiple areas of research and pharmaceutical presence, cardiovascular, renal, hematology, neurological, oncology, radiology, women's healthcare, infectious diseases. And these are the spectrum of products they have. And I'm pretty sure all of us have probably used one or the other product of their at some point of time in our patients. So Bayer Pharmaceutical. Next slide. Chinook Therapeutics. Next slide. Which develops precision medicines for kidney disease, and some of their products are atrasentan for IgA nephropathy and basket of glomerular diseases, Bion 1301 for IgA nephropathy, and CHK 336 for primary hyperoxaluria. And they have a bunch of research and discovery programs focusing on rare and severe chronic kidney disease. So all in all, I want to thank all of our sponsors for a lovely evening that's ahead of us. Thank you. Next slide.
Should I talk number? Is that okay? Yeah. So this is about the, we just wanted to highlight the ISN and ANIO connection in that, some of our programming is jointly organized with ISN, and we hope to have something similar with ASN as well, a joint offering of programming. And the flagship program here has been the nephropathology course, which has large uptake and has been very useful, been around for more than 3 years now, and just a fantastic program led currently by Dr. Bijol. And then we are hoping, we in the past had programs related to exchange of apprenticeship, just type programs, and then we're hoping to reinstitute those this pandemic, but in the meantime implement virtual programming that it offers bidirectional training across India and US and the Indian subcontinent in general. So if people have ideas about that, please feel free to send them to us directly or through the Q&A function here or through chat. But yeah, we are hoping to have some exciting programming working with ISN as well as ASN. Thank you. And also, don't let me forget to introduce our MC for today, who is Priya Deshpande. She is an assistant professor currently at the ICANN School of Medicine at Mount Sinai. She trained throughout her medical career in New York. I don't think you've left the 5 boroughs, Priya. But,
it's so true.
But she has been well recognized for her during her training. She was awarded a teaching award while at Albert Einstein, and currently runs a onconephrology program at Mount Sinai, and has had awards for has been active in the global health programs as well as American Medical Association. And she will introduce our speakers and also sort of guide us through the evening today. So we're looking forward to your engagement today. Thank you.
Thank you so much, Suchi, for that wonderful introduction. I'm trying to advance my slides. I'm sorry. There we go. And thank you, everyone, for joining this evening. I want to take a moment again to thank ANIO and thank our sponsors for hosting and supporting this event. The theme for this evening is kidney disease and vascular risk in South Asians. And we have 3 very accomplished speakers today. Please feel free to post your questions in the chat. But when you post your questions, please post your name, your title, and where you practice. We will do our best to answer the questions during the panel discussion after our 3 talks. And without further ado, I will introduce our first speaker. We'll also turn off my video for saving bandwidth. So our first speaker today is Dr. Alka Kanaya. She is a professor of medicine, epidemiology, and biostatistics at the University of California in San Francisco in the Division of General Internal Medicine. Dr. Kanaya has focused her research program on type 2 diabetes and cardiovascular disease epidemiology and prevention, specifically understanding Asian American health disparities over the past 2 decades. She is co-leading the Mediators of Atherosclerosis in South Asians Living in America, or MASALA study, to better understand the factors that explain the high rates of diabetes and heart disease among South Asians. She's a practicing general internist and leads the CTSI research training programs at UCSF. Welcome, Dr. Kanaya.
Thank you. It's great to be here. I'm going to share my screen. If you could stop sharing.
Yes, I will. Okay, there we go.
Okay. Yeah, but let me know if you can see it well. Yeah, okay, great. So I'm happy to be here, and I'm happy to share some of our data from the MASALA study with you, really focusing in on kidney and cardiometabolic disease. So why did we start the MASALA study? It's really because of data like this. This is the newest data that I've seen come from Northern California Kaiser, where they look at the incidence of heart disease by different race ethnic group. And what you can see here is that in the first set of bars, that's South Asian, light blue is both men and women together, orange represents men, gray is women. You can see that the incidence of heart disease is really highest among both South Asian men and women compared to East Asians, other Asians, Blacks, Hispanics, whites, multi-ethnic, and overall. So this has been seen not only, in Northern California, but it's been seen all around the South Asian diaspora, and no one really understands why, because the traditional risk factors such as diabetes, heart disease, and hypertension and smoking don't really explain this heightened risk. So that was really the crux of why we started the Masala study. So just to show you how we designed Masala, we focused in on middle to older age South Asians in the United States between age 40 to 84. This was an investigator-initiated R01 grant in the speaking that it's a small amount of funding, so we could only include 900 participants who did not have any existing cardiovascular disease, because we're looking at what causes cardiovascular disease. We only included South Asians, so people who said that 3 out of 4 of their grandparents were born in any of the 7 South Asian countries. We have 2 clinical sites, one where I'm located in San Francisco and one in Chicago at Northwestern University. And we completed our baseline exam in 2013 and our second exam in 2018. And I think what makes Masala special is that we have this really strong partnership with the multi-ethnic study of atherosclerosis, which is a very large NIH contract that's been going on now for over almost 20 years, which included men and women from 4 different ethnic groups in the US at a slightly older age, 45 to 84. And the 4 groups are whites, Latinos, Blacks, and Chinese Americans. And they had 6 different sites. So when Masala was starting baseline exam, Mesa was already in the middle of exam 5. But we do cross-compare our statistics with MESA, because we're using the same exact eligibility criteria and also the same methods, the same reading centers, the same research labs that do the assays for us. So here's what we've accomplished in the last decade in Masala. We did the baseline exam in 2010, and then we did some social networks mapping a few years later. And then in 2016 to 2018, we completed exam 2, where we brought back almost 83% of the population to repeat their glucose tolerance tests and cardiac CT scans. And we added a new subset of 258 new participants in the study, really trying to get more diversity in the South Asians that are represented in Masala, because it's you'll see the characteristics of our study population. And we just received notice today, in fact, that we are funded for exam 3, which will start later this year and will focus on cardiac function. So here are the few of topics I'd like to cover. I'll show you the demographic and behavioral characteristics of the people in Masala, the diet that South Asians in the US are eating based on our data, so the prevalence of CKD, and then body composition and diabetes. So 98% of the population of our study are immigrants to the United States, and that is because of the age group that we're studying with the immigration laws as they were that opened up in the mid-1960s. The only immigrants that were allowed to come from parts of Asia had to be highly educated or seeking professional education and higher degrees here. And so most of the population, 83% was born in India, 6% from Pakistan, and then 1% from some of the other South Asian countries. So only 2% were born in the US in our second generation, and those people were really in their 40s. And so let's look at the lifestyle and behavioral risk factors. And this table shows you the Masala South Asians between age 45 and 84 to be comparable in age distribution to the 4 groups in MESA, our sister study. You can see that the South Asians and the Chinese in MESA were least likely to be current smokers. Only 3% of South Asians and 6% of Chinese, and the other 3 race ethnic groups had higher prevalence of current smoking. Alcohol use was also quite low to moderate among the 2 Asian subgroups that are represented here. But exercise was actually quite low among the South Asians. And that's using the same questionnaire that's been validated in multiple ethnic groups that asks about leisure time activities, as well as occupational, as well as, any kind of activities that are done in volunteer and other basis. So that is quite, striking. And of course, this has been seen in many other countries around the diaspora as well, and a very important modifiable risk factor. So what about foods? Everyone is very interested in learning about what foods are, healthy and less healthy, and everyone has their, opinions about food being one of the main culprits for this high risk of cardiovascular disease that we see in South Asians. So we spent a lot of time thinking about how best to measure food. And because these, the participants in Masala are mostly immigrants, they're eating many of their traditional Indian foods or South Asian foods, but they're also adopting American, Western foods in their diet. So we ended up going and using the SHARE food frequency questionnaire that was developed in the Canadian study in the early 2000s, where they both created and validated a new food frequency questionnaire that was developed in Pakistanis, Bangladeshis, and Indians living in Canada. And this is a very, complex food frequency questionnaire. And we used all of this data together to look at dietary patterns, which is one of the best ways that nutritional epidemiology is moving. And what we found was there's 3 major types of diet that participants consume. And it's about a third in terms of the major type of dietary pattern. About a third of participants are consuming a diet that's high in animal protein, more of a Western diet. A third are consuming a more traditional South Asian diet that is high in fried snacks, sweets, and high-fat dairy products. And a third are consuming more of a prudent diet that has fruits and vegetables, nuts, and legumes. Now, looking at these pictures, you would think that, well, this one on the right here looks like a vegetarian diet. True, about 50% of people in this major dietary pattern were vegetarian, but the other 50% were also consuming some level of meat, but it wasn't a major component in the diet. But 50% of the people in this fried snacks, sweets, and high-fat dairy were also lifelong vegetarians, but were also consuming other types of meat. So when we look at these patterns and how they're associated with cardiometabolic risk, we found that those eating the animal protein or Western diet had more of an adipose or a higher adiposity phenotype with higher weight and a bigger waist circumference. And then the people in the middle here had more of an insulin resistance phenotype with both lower HDL cholesterol, higher indices of insulin resistance, and higher blood pressure. And the reference group was the fruits, vegetables, nuts, and legumes group. And so moving on to show you some of the hypertension data compared to MESA, the African Americans in MESA had the highest prevalence of high blood pressure. This is measured both by, seated blood pressure greater than 140/90, or the use of antihypertensive medications. Masala South Asians were second most prevalent with hypertension, almost 46%, and compared to the other groups. And so that brings me to CKD prevalence, and I thank Suchi Anand for doing this lovely analysis of Masala data. And what she did was compare our data for CKD with contemporary data of a cohort that has been created in India, in 2 centers in India, Chennai and Delhi, called the Cardiometabolic Risk Reduction Study. And we use the same age groups. They were contemporary in time, these 2 studies, when they happened together. And the overall age-adjusted prevalence of chronic kidney disease was somewhat higher in Masala, 14%, compared to almost 10.8% in CARS. And there was a difference by sex. So the CKD prevalence was very similar between men in Masala. And we've only included Asian Indians for this analysis. We excluded people born in other South Asian countries or other diaspora countries, just to make it, apples to apples comparisons of Indian immigrants in the US to native Indians in these 2 parts of India. And what she also found was that when we look at the difference in prevalence for men, there was a slight difference with higher prevalence in Masala but that was fully explained by differences in age, as well as waist-hip ratio and diabetes prevalence between the two studies. However, looking at the difference in prevalence of CKD between women in US versus India, the Masala women had a much higher prevalence of CKD, which was mostly due to microalbuminuria. So when we look at the definition of CKD and we split out albuminuria with eGFR, and this is just using the CKD epi equation, you can see that in serially adjusted models that this difference that exists between Masala and CARS women does not diminish. It stays strong with the Masala women having higher levels of microalbuminuria or any albuminuria compared to the women in India, whereas the eGFR is somewhat, is not as significant. So Suchi did some nice analyses looking at comparing social and lifestyle factors only among the women with CKD in these two studies. The dark gray shows you if a woman did have this risk factor or not. So she looked at differences in income in the top tertile. And here's where you can see that in Masala, the women with CKD were less likely to have income in the top tertile. But in India, the women there were more likely to have higher income. So we know there's a socioeconomic gradient that's associated with CKD, which is reversed in India compared to the US. And the other factors, including education, as well as physical activity and fruits and vegetable intake, were similar in that there was, it was higher in both women in Masala and CARS. So now when we look at, both these studies side by side, so the light gray bars represent CARS and the prevalence in CARS, and the dark gray shows you Masala prevalence. And here she's looking at all of the different risk factors that may be associated with CKD. Diabetes, there was somewhat higher prevalence of diabetes among the CARS population than Masala. But what's interesting is if we look at people on diabetes medications and those with better control of their diabetes with A1Cs less than 7%, you can see that the Masala participants had somewhat better control, 17% versus only 2% in CARS. Same situation with hypertension. While hypertension was slightly more prevalent among those with CKD and CARS, the medication gap seemed to be even greater, with 44% of Masala participants being on antihypertensive and having 30% who had controlled blood pressure. ACE-ARB use was also much higher in Masala. Levels of, having a LDL less than 100 were somewhat better in Masala as well. And if we look at other self-care activities, like physical activity was bad in both studies, but was somewhat better in the Masala Indians, and the fruit and vegetable intake was much higher in the Masala Indians compared to the CARS Indians. And what I find very striking about this is if we just look across the board, comparing Masala to CARS, the number of fruits and vegetables eaten by any of our participants is close to 4.5 per day, whereas in CARS it's more like 2.3 per day. So that's just a sad reflection of what the diet looks like in current day different parts of India. Awareness of kidney disease was abysmal in both studies, only 6% in Masala and 2% in CARS. So let's move on to adiposity, because this is one of our big interests in Masala, is really to understand differences in body composition. And as you all know, the WHO has recommended lower BMI cut points for overweight among Asian populations from 23 to 27.5, and obese greater than or equal to 27.5. And when we just look at the prevalence of normal weight, overweight, and obese, with red being the South Asians in Masala and the other groups being reflected in different colors in Mesa, you'll see that the overall prevalence of normal weight was only about 25%. A quarter of the population in Masala were of normal weight when you use the correct BMI. The Chinese had many more in the normal weight category. In terms of overweight, all of the groups had about a 40 to 45% prevalence of overweight, and obesity was almost 30% in Masala. However, one thing we were really, interested in learning about was not only just a BMI measure of obesity, but really about fat distribution, since we've known about this paradox with the thin fat phenotype being so common in South Asians. As you all know, this is Dr. Yudkin, a European scientist with a BMI of 22.3, and his colleague, Dr. Yajnik, is from Pune, India, and he had the same BMI, yet when you measure body composition with a whole body DEXA scan, and the body fat is almost 2.5 times higher for Dr. Yajnik, from 9% to 21%. And so this has always been kind of one of the biggest theories about why there must be so much more cardiometabolic disease. And so in Masala, we've spent some time and energy in measuring ectopic levels of body fat in the muscle, in the liver, and around the visceral adipose site, as well as around the heart in the pericardium. And we've used CT scan and software to measure visceral fat. So here's a cross section through the lower part of the abdomen. The light green shows you subcutaneous fat. The light blue is visceral fat, and the light blue here in the muscles are, again, intermuscular fat. We can't use the software for the liver, so we use regions of interest to look at liver fat attenuation. And what we found comparing to MESA, again, using the same exact protocol, same reading centers, and this is after adjustment for cardiometabolic risk factors, South Asians actually store fat in all of the wrong places compared to the 4 groups in MESA. South Asians had more visceral fat, more fat in the muscle, more fat in the liver, and low levels of lean mass, lean muscular mass. So before I move on, I wanted to show you some of our cystatin data that we've measured in a pilot study in Masala, where we calculated the eGFR using the cystatin equation. And we did find nice, inverse linear associations between higher age, higher systolic blood pressure, CRP, BMI, and diabetes associated with lower levels of eGFR using cystatin C. Then we wanted to see whether these ectopic fat stores were also, associated with the eGFR levels. And without adjustment, if you just look at the unadjusted data, there seems to be strong associations for body mass index, waist circumference, subcutaneous fat, visceral fat, not really liver fat. With the eGFR measure. But once you adjust for all of the cardiovascular risk factors and CRP as an inflammatory factor, this association does go away. So that's an important fact, that we don't think adiposity itself is an independent reason why there may be a somewhat higher prevalence of CKD. So in Masala, the diabetes prevalence was quite high, 26% overall, and this is using both fasting glucose, 2-hour glucose tolerance, as well as a self-report of someone taking a diabetes medication, and a third had pre-diabetes. And how does that compare to the MESA groups? Here, men shown on the left, red being diabetes, and the first bar is South Asian men. 30% prevalence of diabetes in the South Asian men, much higher than the other men in MESA. But the South Asian women, 15% diabetes prevalence, half of the South Asian men. This sex difference in diabetes is seen worldwide, but it was quite stark in the Masala study. And you can see that South Asian women had higher prevalence of diabetes, but somewhat lower than African American women in MESA. So after we adjust for all other risk factors that could contribute to diabetes prevalence, all sorts of different risk factors, you can really see a major difference with the South Asians having almost 27% prevalence of diabetes compared to 6% in whites, 16% in African Americans and Chinese, and 14% in Latinos. And why is that? So we removed the people with diabetes from this analysis and looked at levels of insulin resistance measured by a surrogate measure of HOMA, glucose and insulin together. And we find that South Asians without diabetes had much higher levels of insulin resistance, but also much lower levels of beta cell function. And this is something that is quite ignored in the literature, that everyone's very focused on high levels of insulin resistance as being a driver. But actually this lower level of beta cell function is fascinating because there may be evolutionary as well as lifestyle reasons why this may be a problem, as well as environmental toxic and pollution reasons why there may be, earlier decline in beta cell function, something I'm very interested in terms of prevention of type 2 diabetes. So with that, I'm just going to wrap up and show you some of the key lessons. South Asians do have a higher cardiometabolic risk than most race ethnic groups in the US compared to the MESA groups. And this adverse body composition may be somewhat culprit, especially in driving some of the rates of diabetes that we see. The CKD prevalence is much higher among the Indian women in the US in Masala compared to Indian women in CARS, and it's mostly microalbuminuria. And it's there's no clear independent association between the ectopic adiposity, though, and the CKD that we've seen. We just have a long way to go to achieve optimal risk factors, but I think the glass half full here is that there are many modifiable risk factors for CKD, and so we have a lot of work to do together to help with prevention. Thank you for your time. I'm going to show you our website. Please visit it. We have all of our publications posted. We have a very transparent data sharing policy. If you are interested in analyzing our data, it's a simple, straightforward policy of how to propose an analysis plan. And we also blog to make our findings more digestible and accessible to the South Asian community at large. We have a lot of health tips, nutrition, lifestyle, as well as cardiovascular disease related tips for participants in our study and the larger South Asian community. And with that, I thank you for your attention. And I guess I will wait till the end to take questions. I'm going to stop sharing my screen.
Thank you so much, Dr. Kanaya. That was an amazing talk, and thank you to Shuchi as well for your amazing work that you did with Dr. Kanaya. I'm just sharing my screen again. Our next speaker is Dr. Nisha Bansal. Dr. Nisha Bansal is an associate professor and the Arthur Stack Family Endowed Professor of the Division of Nephrology at the University of Washington. She is also an investigator in the Kidney Research Institute, the Associate Fellowship Program Director, and the Director of the Kidney Heart Service at UW. Dr. Bansal is an NIH-funded physician scientist whose work has advanced the understanding of cardiovascular disease among the high-risk and growing population of patients with chronic kidney disease. She is also an associate editor for Kidney 360. Dr. Bansal has played an important role in mentoring locally and nationally through multiple leadership positions and has received numerous accolades for mentorship. I'm going to stop sharing.
Thank you so much. Thank you so much for the kind introduction. It's a real pleasure to be here today. Okay, let me know. Is the view all right, Priya?
Yes. Yes, it is.
Okay, great. Thank you so much. All right. Well, it's my pleasure today to talk about assessment of kidney function in South Asian populations, which I think after Alka's wonderful introduction about CKD risk factors, it's important to think about how we're measuring kidney function in these patients. So my disclosures are here. So as most people on this webinar today know, glomerular filtration rate, or GFR, is the crux of assessing kidney function. Given the impracticality of directly measuring kidney function, or GFR, in all patients every day for clinical use, we rely heavily on estimation of GFR. And estimating GFR correctly is an important goal for many reasons clinically. One, getting GFR estimation right allows us to adequately identify those who have chronic kidney disease, and this subsequently leads to subspecialty care, such as referral to nephrology, as well as intensive management of CKD risk factors, as Dr. Kanaya had mentioned earlier in her talk. We also know once patients are diagnosed with chronic kidney disease, accurate estimation of GFR leads to other important referrals and management of their kidney disease, such as planning for vascular access. We also considered GFR and estimation of GFR in terms of thinking about eligibility for medications, namely two important ones include metformin and more recently SGLT2 inhibitors, which are approved for those who have an eGFR greater than 30. And finally, in the US, we use a hard cutoff of an eGFR of less than 20, which allows patients to be referred for kidney transplant and start accruing wait time once they are approved for kidney transplantation. And so eGFR estimation clearly has important clinical implications. However, it should be noted that there's been recently a lot of scrutiny over GFR estimation as our current equations that we use adjust for race, namely Black versus non-Black race. And in Black persons, this raises the eGFR compared to those who self-identify as non-Black. And I'm going to briefly go over what this has meant in terms of the Black population, and then explain how this would apply to our patients of South Asian descent as well. And so in patients who self-identify as Black, we apply a race coefficient of 1.159 to these patients, which then raises their eGFR. And this has brought about a lot of speculation of why we do this. It's been noted that serum creatinine is higher for those who are African American or Black. And it's raised the question, are these true differences in kidney function? That is, do persons who are Black actually have biologically different kidneys? Or is it reflection of other biological factors such as differences in muscle mass? More likely, it's been agreed upon that it's a reflection of social determinants of health. And it's important to distinguish between race versus ancestry. So race is a social construct versus ancestry, which is your genetic composition, which is a biological construct. And by assigning a coefficient for race in patients who identify as Black, we are in a lot of ways ignoring the ancestral diversity of these patients. And two, how we assign this race coefficient or this designation of race is often problematic. It's done in the medical setting where often medical providers decide what race you are by looking at a patient. And this in turn can introduce bias.
Nisha, sorry to interrupt.
Sorry. Oh, sorry. We see a presenter mode. We don't see the
I'm sorry.
slide. No worries.
Is that better?
Perfect.
Yes.
Okay, thank you for noting that. And so what has this done? And so there's been a lot of literature recently looking at what the effect of applying this race correction is in patients who are Black. And so this is a report that was just published this year, which looked at both patients in NHANES, which is a national survey of US persons, as well as US veterans. And they compared estimates of the prevalence of CKD in the NHANES population with and without this race adjustment, as well as in the VA system. And what they found was that taking out this race correction in the eGFR estimation increased the prevalence of CKD from 5.8 to 10.4%. So a substantial increase. Similarly, in the VA system, the prevalence of CKD increased from 15.5 to 26.3% in persons who identified as Black. Another analysis studied patients in a healthcare delivery system, and they looked to see how many patients would be reclassified if we took away this race correction in Black patients. And what they found was that about 33% would be reclassified to a more severe stage of chronic kidney disease, which potentially could have implications on their healthcare. And so most of the reclassification occurred here from stage 3B, stage 3A to 3B, and smaller numbers of patients were reclassified to more severe stages of CKD after that. However, notably, they did note about 3% of patients were reclassified from above eGFR of 20 to below this eGFR of 20, which is that threshold that we discussed earlier that's used for referral for kidney transplantation. We also look at this, this question about transplant eligibility as well in a national cohort study of patients with chronic kidney disease. And we found that overall there was a difference of almost 5 mLs per minute in eGFR when the race correction was not used compared with when the race correction was used. We then looked at, over time, what would be the effect of not using this race correction and estimating GFR in terms of time to an eGFR less than 20, which is again the time to potential transplant eligibility. And this is represented by this yellow line here. And you can see that patients are more likely to reach this threshold, this critical threshold of an eGFR less than 20 earlier, just by the way that we're estimating the eGFR. They haven't changed, or kidney function hasn't changed, simply the equation we're using is different. And we found that they're more likely to receive this threshold over 4 years, with an association of about 35%. And the time to reaching this threshold differed on average of about 2 years, simply by just taking away the race correction factor, meaning the same patient could have been referred to transplant 2 years earlier just because of differences in the way we're estimating eGFR. And so how does this apply to patients of South Asian descent? And so there's a lot of questions that arise, I think, in this population when thinking about kidney function. One, we have this really bimodal race coefficient. You're either Black or non-Black. And which one should we be using in patients who are South Asian? Or do we need a specific equation? Again, I think it is important to recognize both the geographic diversity of South Asians as well as the ancestral heterogeneity of this population when thinking about these questions. Although there has not been a lot of data to answer these questions, I will present what we do know. And so the first question arises, well, what is normal GFR in patients or in South Asian patients? Is it the same as their non-South Asian counterparts? And so in patients who are of European origin, it's thought that when patients are about 20 of age, they have a GFR somewhere in the 125 to 150 range, and it declines about 1 ml per minute per year. And so Dr. Jafar, who's one of our panelists today, has done a lot of the seminal studies in terms of assessing kidney function in Pakistani patients. And so she did a study in which she sampled 530 participants who are over 40 years of age in Pakistan. And she excluded those with known kidney disease and those who had kidney disease risk factors such as diabetes and hypertension. So in these patients, she directly measured GFR using inulin clearance and found that overall the mean measured GFR in this population of patients without kidney disease who are over 40 years of age was 94. And this is looking at the inulin clearances in men versus women. And you can see they're fairly similar. However, over time, GFR declined about 0.79 for every 1 year higher in age. And this decline in GFR was more pronounced in the men versus the women. She and her group then compared the inulin clearance in men versus women in this cohort of from Pakistan, which is denoted by the black line here, compared with the European cohorts in the US, which is the gray bar line here. And you can see that on average, there's a modest difference in terms of the measured GFR, which is slightly lower in this Pakistani population. So knowing that there could be differences in measured GFR, it's important to think about, well, how are we estimating GFR in these patients? How well do our existing equations work? Should we be modifying our existing equations, or should we be developing new equations for estimation of GFR? And so there was a study by Teo et al. That was published several years ago, which compared measured GFR to the CKD epi equation versus the MDRD equation versus a modified MDRD equation, which include an Asian coefficient. And so this study included 232 patients, of whom about 28% were Indian or other. And they compared the bias and precision of these equations compared with measured GFR. Overall, CKD, EPI, and MDRD were fairly comparable, maybe with marginally less bias and precision, more precision in the CKD, EPI, but I would say fairly comparable. And they did not find that including this Asian coefficient actually improved the accuracy of this estimating equation compared with measured GFR. Another study also looked at this question about, should we be potentially including a race coefficient? And to do this study, they took a large cohort of 10 pooled studies over 8,000 participants, and they developed a new equation and then externally validated it in almost 4,000 patients. And they defined race in the estimating equations for GFR in two ways. One was the traditional way using a 2-level variable, Black versus non-Black. And the second was a 4-level variable, Black, Asian, Native American and Hispanic versus white and other. And so they first looked at how these, what the coefficients were for these, for the racial groups in this estimating equation. And what they found was that that eGFR using this 4-level equation was higher in Asians compared with whites. So this means that for the same level of serum creatinine, the estimated GFR was a bit higher. They then compared the performance of the 4-level race coefficient, which included specifically a coefficient for Asian race, versus the 2-level, which was simply the Black versus the non-Black coefficient. And they looked across eGFR categories. And so this figure is looking at the measured GFR minus the estimated GFR. So the higher the height of the bars, the greater the inaccuracy and the difference between these two measures. And so I've highlighted here the data in the Asian population. What you can see here is that across ranges of eGFR, in fact, the 4-level race coefficient had less accuracy compared with the 2-level coefficient. So knowing this, there's been subsequent studies as well. So Dr. Jafar and her colleagues did another study where they again studied this large cohort of patients from Pakistan, and they compared the CKD-EPI equation, the MDRD equation, and then two other equations to measure GFR. So they looked at a modified CKD-EPI equation, which included a new coefficient, and they actually developed a new series of equations, two new equations using a range of other variables, and they called these the PK equations. And so again, these figures are reporting the bias in these estimates. And the equations with the least bias will fall along this middle line along 0. And so first, in looking at the MDRD equation, you can see that compared with measured GFR, that in fact, at the higher ranges of measured GFR, there's more bias in this population with MDRD. The CKD-EPI and the CKD-EPI-PK equation both perform comparably well with less bias compared to MDRD. And then these new equations that were developed also perform fairly well, as particularly compared with the MDRD. So far, we've really focused on serum creatinine as our filtration marker. However, as we know, there are some alternative filtration markers out there as well. And so the first one that's probably been the best study is cystatin C. Cystatin C is a protein that's also a great marker of filtration in that it's freely filtered, neither secreted nor reabsorbed, and it's clinically available in many sites in the US. And so this study looked at, this is also by Dr. Jafar's group, looking at a cohort of patients from Pakistan, comparing measured GFR with various estimating equations, including eGFR by cystatin C. And what they found, as you can see here, is that in fact, eGFR creatinine overestimated measured GFR with a large negative bias of -7, while eGFR cystatin actually underestimated measured GFR with a positive bias. It appears that maybe the combined equation had the least bias in terms of the compromise between these two equations. And then more recently, there's been an interest in finding alternative filtration markers beyond cystatin C and creatinine. And so this is a paper that was just recently published that looked at beta-2 microglobulin and beta trace protein as part of a 4-marker GFR model. And this 4-marker panel included creatinine, cystatin, beta trace protein, as well as beta-2 microglobulin. And they included age and sex, but no race in the estimation of eGFR. And they compared the performance of this 4-marker race blind panel to eGFR, creatinine, and cystatin C equations. And so they looked at 2 measures of accuracy. One was looking at the percent of GFR estimates that differed by measured GFR of greater than 30%. So the further from this line here, the greater the imprecision. And then they looked at the bias, which was the difference between the measured and the estimated GFR. And again, you want to get as close to this 0 line as possible. And I've circled here the performance of the 4-marker equation. And you can see that it performed fairly well in terms of precision and bias. That was on par with some of the other equations that we use clinically, however, does not include a coefficient for race. And so this may be an important next step. It should be noted that this study only studied North American and European populations and did not test the performance of these equations in South Asian populations. So to wrap things up, what we've seen is that I would say based on the current body of data that we have, the CKD epi equation using serum creatinine is perhaps our best option for eGFR estimation in persons who are of South Asian descent. I think that this field is important and there's a lot of further work that needs to be done, specifically thinking about alternative filtration markers that may improve our estimation. I think the work on cystatin C is quite promising, as some of the other more novel filtration markers. And eGFR estimation is important. We've seen, at least looking at the data that we've seen in the last 2 years in Black patients, that it significantly impacts our clinical management and therefore our health outcomes in patients with or at risk for kidney disease. And we've seen from the previous talk that patients from South Asia are certainly at enhanced risk for kidney disease. And so thank you so much for your attention. And I'm happy to take questions during the panel discussion at the end.
Thank you so much, Dr. Bansal. That was amazing. And I would like to continue moving on to our final speaker, Dr. Jafar. And we already got a taste of the wonderful work that she's done in Dr. Bansal's talk as well. So I'm going to introduce Dr. Jafar. Let me just pull up my screen here. Sorry. I want to stop sharing. Oh, sorry. Okay, I think Dr. Jafar is sharing her screen at this point. But let me just go over her bio really quick. Dr. Tazeen Jafar is a professor of health services and system research at the Duke NUS Medical School in Singapore and visiting consultant in renal medicine at the Singapore General Hospital. She's also a professor of global health at the Duke Global Health Institute and a consultant nephrologist at the Durham VA Hospital here in the US. She has a 20-year track record of several landmark studies, including the meta-analysis of ACE inhibitors in non-diabetic kidney disease, GFR estimation equations in South Asians. She's also led clinical trials and implementation research on hypertension, including control of blood pressure and risk attenuation, Bangladesh, Pakistan, and Sri Lanka study, also called the COBRA BPS study, which was published in the New England Journal of Medicine in 2020. Professor Jafar is a recipient of the International Society of Hypertension Boehringer Ingelheim Developing World Award and leads the ISH College of Experts. Welcome, Dr. Jafar. Sorry.
You're on mute, Dr. Jafar.
Can everybody see Dr. Jafar's slides? Oh,
Okay, can you hear me now?
Yes.
Okay, excellent. All right, so I just started with saying how delighted I am to be here, and thank you, Kinar and Suchi and team for inviting me. Also the preceding two talks were completely fascinating. And I think my talk is going to be more on the management side, as you can see the topic. As the title of my talk is Management of Hypertension and Cardiometabolic Risk Factors in South Asians, my disclosures. So here's a brief overview of what I'm going to be talking. I'm going to try and wrap it up in the next 20 minutes. I know it's kind of late, especially for those of us, and I'm also in the on the East Coast right now. So I'm going to be talking about the burden of hypertension in South Asia. Why South Asia is at a higher risk of CVD and CKD, and you've already heard a lot about this today, so I'm not going to dwell on this much, but going to discuss a little bit more about why CVD and CKD case fatality rates are high and health systems are weak in South Asia, especially in the rural areas, and why so we need to focus more on management and prevention efforts there. And from a health systems perspective, then discuss what works and what doesn't work in terms of effectiveness. And then our own experience, investigator experience on the community-based interventions on management of hypertension, and how they will then also will extend to a little bit to CKD, especially with regard to the COBRA BPS trial. And then based on that, the recommendation that way forward. And again, I'm going to try and do this in 20 minutes, and we can go into more detail during the Q&A session. So these are data from the Global Burden of Disease, recent data. And as you can see here, the panel A is showing the leading attributable risk factors for death in women, and panel B is showing in men. In 2019, 19% of all deaths, which is 10.8 million deaths, were attributable to high blood pressure, and high systolic blood pressure is the leading cause of death in women, and the second leading cause of death after tobacco in men. So huge, huge problem, obviously globally, and it's not a surprise because 1.4 billion people are affected by high blood pressure. And unfortunately, I mean, more than 3/4 of those people live in low and middle income country, and that's my again, contention that we really there needs to be an increased emphasis on prevention, especially in the low and middle income countries. And so these are data from the PURE study, Salim Yusuf and team. And it's not just a numbers game. So it's not that we have more people in the low and middle income countries. That's why we are seeing a greater burden there. Unfortunately, you can see here, if you look at the prevalence, that the prevalence of hypertension is also high. So, and we've heard a little bit, from Alka's talk, especially in South Asia, and I'm going to talk a little bit more about that too, that the higher risk of hypertension and cardiometabolic diseases, and you can see that reflected here as well. So the prevalence of hypertension is high, awareness is low, treatment is insufficient. So we've heard about that, and we can see that reflected here. And the worst thing is that control is really poor. And especially in the rural communities in the low and middle income countries, which serves as a rationale for our work that we've done, which would say that needs to be scaled up. And again, this is saying why the risk starts. Alka said that, in the Masala study, was showing that it's how this adiposity, the risk of in South Asians, in the adults. Well, this risk starts very early in childhood, or perhaps even in utero. So the risk factors are, some genetic risk factors, epigenetics, lower birth weight. I'm not going to go into the details of that, but those are the predisposing factors which lead to the intergenerational cycles of high risk phenotype in South Asians that we've seen. So even if, and that's why the diaspora, wherever the South Asians move, will carry this risk obviously with them of generations of some kind of a deprivation, perhaps. And those are the theories, obviously needs to be proved. And then with that, the exposure to sedentary lifestyle, or environments of excess where you have lower weight gain is completely detrimental. And there's expression of raised blood pressure, insulin resistance, and enhanced inflammatory responses. So in addition, so not just the diabetes and hypertension itself, but also other risk, other inflammatory conditions, and then the gut microbiota, and which leads to more cardiovascular disease, more kidney disease, and that too at a younger age, right? And also adverse outcomes. And the other thing about living in impoverished environment are obviously poverty, lack of education, lack of access to healthcare, which it acts synergistically, leading to more adverse outcomes. The global trade policies, we've heard about fruit and vegetable intake. Unfortunately, I mean, these diets and poor diets, fruit and vegetables are, the trade policies are such that the produce are, unfortunately, the good produce are all exported from these countries. And therefore, even if you're living in rural areas, you will have very limited access. And so those are the kinds of things that need to be addressed for a comprehensive response to non-communicable diseases and cardiovascular disease and kidney disease. So I just want to highlight that all of these things are together and need a comprehensive action at all levels. At any rate, so we've also compared the blood pressure levels. This was done in children aged 5 to 15 years. And we compared in Pakistani children versus white children. This is from the NHANES, white children in the US. So the solid line is for Pakistani children and the dotted line is for children in the US. This is systolic blood pressure and diastolic blood pressure. And as you can see here, that even in the younger kids, the BMI specific levels of blood pressure were higher in Pakistani children. So this is, again, clearly saying that the risk in South Asians will start very early. There are similar data for glucose intolerance and from India, showing even kids as young as 2 years old will demonstrate that the risk will start very early in life. And then this is Salim Yusuf's work again from the PURE study, showing that it's not only the risk high, it's the comparing high income, middle income, and low income countries in terms of cardiovascular events rates and then case fatality rates. So in more events in middle income countries, and then a urban rural divide. So if you're living in a middle income or low income country, you're more likely to have an event. And if you're living in a rural area compared to an urban area, you're more likely to have an event and also more likely to die from that. And obviously, there's very poor revascularization available treatments, and the preventive care is bad. And then once you have an event, their access to any kind of treatment is bad. So again, making the point that more efforts are needed in low and middle income countries, and more efforts are needed, especially in rural areas, both in terms of prevention and in terms of some very preliminary treatment. And we are unfortunately seeing some of that in our current COVID crisis as well. We can draw parallels to that, unfortunately, and it spills over to pretty much everything. But here we are seeing that in cardiovascular disease and kidney disease. This is the rise in premature death from CKD in India. Deaths in 5 to 69 years old, from 2001 to 2003 to for the next 10 years. There was a 1% increase, absolute, in the number of premature deaths from CKD in India, which is quite marked. And obviously that's the of this age group is going to have a huge impact on the national economy. And then, of course, the social consequences are also going to be tremendous. So that, And if you look at the attributable risk factors for the deaths in the region, so we are comparing this, we are showing India, Bangladesh, Pakistan, Nepal, Sri Lanka. These are again data from Global Burden of Disease. If you look at the attributable risk factors, the key attributable risk factors for CKD deaths are systolic blood pressure and high blood glucose, right? And these are, so the point here is that these are modifiable, right? So, and we know that reducing blood pressure, loads of literature, loads of trials, individual level trials showing that lowering blood pressure reduces cardiovascular events. A 5 millimeter decline in blood pressure will lead to almost 20% benefit in cardiovascular morbidity and mortality. The higher the blood pressure, the greater the benefit, especially so in the younger individuals. So a lot can be done. The question is how to do it at a health system level, right? That's the question. And we projected the benefits, right, of on just a 3 millimeter reduction in systolic blood pressure at a population level. We did this for the Pakistan Lancet series. And this is for age 30 to 69, again, a productive or a younger population. So how many deaths can we prevent just by a 3 millimeter reduction in systolic blood pressure over 10 years? And we also compared that with the other kind of interventions like reduction in tobacco use, reduction in fasting glucose level, increasing physical activity, and just the reduction, small reduction in systolic blood pressure can prevent a lot of deaths, and perhaps was going to be as a single intervention the most important. Of course, other interventions are also important, and combined intervention was going to be yield the most benefits. But as a single intervention, I just want to highlight that point, that it is one of the key interventions or most significant interventions is reduction in blood pressure. And if you do this at a regional level in South Asia, millions of deaths and premature deaths can be prevented. The question is, how do you do that, right? Individually, we know when the patient comes to our clinic, we know how to do it, but at a health systems level, that is the challenge. And so this is a Cochrane review of health systems strategies or quality improvement initiatives. What type of initiatives work, right? And so, you know, when we educate, do patient education, physician education, just CME activities, and so these are a number of trials, you know, 50 trials, and each one of these dots are showing a large number of trials. So just a single interventions, for example, physician education will have modest effect, if any at all. Patient education, or giving them pamphlets or just simple patient counseling by itself only will have, again, you know, absolutely minuscule benefit. Self-monitoring, a little bit, not much, but but organized care where you combine, organized care where you're combining a lot of interventions together, training for our team-based interventions, they tend to have more significant benefits. So these were largely based on pre-post kind of interventions. Now, how would that, these are data from the West. What would work in a low and middle income countries, especially in South Asia, where interventions are needed so badly, where blood pressure levels are high, and we know that cardiovascular mortality is high, and care, unfortunately, is completely fragmented. So our goal in the COBRA trial, which is something that we planned in early 2000s and completed this in 2010, was to come up with a model of care that was effective and cost effective and sustainable. And this cluster randomized trial was done in Karachi in 12 clusters, and we evaluated 2 strategies. That was home health education. The other one was training GP, and I'll give you the rationale for why these 2 strategies. And these were clusters of households that were, so not individual patients, but clusters of entire communities were randomized. In a factorial design, such that we had 3 communities to home health education alone, 3 to a combined intervention of home health education and training the GPs, 3 to a usual care, which is no intervention, and 3 to training GPs alone. So it's a factorial design study. Our first intervention was home health education, and this home health education was really modeled on the DASH diet, which you're very well aware of a diet that's low in saturated fat, more fruit and vegetables, low in salt, maintaining an ideal body weight. And the rationale behind this was in the many low and middle income countries, especially in South Asia. In Pakistan, they have the Lady Health Worker program. In India, they have the activated social, the ASHAs. In Sri Lanka, they have the public health midwives. And in many of the low and middle income countries, they have these community health workers or non-physician health workers who go to door, and they are providing a lot of maternal child health services, growth monitoring services, but they didn't have the mandate to provide non-communicable disease or hypertension care. So we wanted to build a model that was, again, going to be sustainable. We said, well, what if we train these community health workers to go and home and provide healthy home health education around hypertension management and prevention. And we also trained them in behavior change communication strategies, and of course on medication adherence, and designed a curriculum, again, which was with the nutritionists, epidemiologists, clinicians. So that was our strategy one. Our second strategy was the intervention. And here is a community health worker who then went, and then when the community health worker goes into the homes, the entire household, although the education is directed at the hypertensive individuals, you'll see that the kids will also sit around and participate in the session. The second strategy was training the physicians. And in this original COBRA, which was done in Karachi, again, these are community physicians who are really private contractors. So we trained them in the updated guidelines and gave them a certificate of training. And so this was the second strategy. We followed them for 2 years. These are our results were shown here. This is decline in systolic blood pressure. This is the no intervention. And what we found, so our last row here, as no intervention. And so as you know, placebo, you'll see that there's going to be some decline. So blood pressure declined in all 4 groups, but we found an interaction between home health education and trained GP, which is significant interaction. And the decline in blood pressure was most significant by greater by 5 millimeters mercury compared to no intervention or single intervention in the combined intervention group. And the single intervention, home health education only or trained GP, were not different from no intervention. But the combined intervention worked. We also did a cost effectiveness analysis, which I'm not showing here, and it was highly cost effective. We also followed these participants post-trial after 7 years, and we had a eGFR CKD-EPI GFR, which is with the South Asian coefficient. So CKD-EPI at baseline and then at the end of 7 years. And so this is the usual care. In the usual care participants, the eGFR fell by almost 4 milliliters per minute. But in the combined intervention group where we had the benefit, right, there was no change. So again, here we are seeing that there is an improvement, relative improvement in eGFR in the combined intervention group. We're not going to make much of, I mean, I think this is very suggestive of a benefit because this is a post-trial. And there was there's still a relatively high dropout rate here, but I would see this as a very indicative of a potential benefit on eGFR as well. So this was our initial COBRA, which, like I said, was also cost effective. There are subsequent studies of the community health-led worker model, which was shown to be effective in Argentina. There was one in Nepal. There's one in Malaysia and in Colombia. On hypertension care model, similar kind of an approach. However, most of these trials, almost all, were predominantly in urban areas. And even our community workers that we took were actually, we hired them just for the trial to set up a model of care. The question then was, are we going to be able to use the government community health workers as well? Are we going to be able to scale, implement this large scale implementation in the government sector? Because, you can, when the community health worker is doing her or his task and also then do this task that they're supposed to do, hypertension care management as well. So that was one question. The second question was, we've just done in the urban areas? Is it going to work in the rural areas where there are lots of differences in the healthcare setup, in the population, education level, and of course in the physician level, because the urban physicians are different, the rural primary care setup is different. So is it going to work in the rural areas? And we did the study only in Pakistan. Is it going to work in other South Asian countries? So how, and our interest was obviously to build a program that would work across the region. So we did the Cobra BPS trial, and now this one was in rural Bangladesh, rural Pakistan, and rural Sri Lanka, 30 clusters. And we further adapted. And so it was initially the 2 interventions, home health education and trained GP. And we adapted that further for integration into the government setup. So now we trained the government community health worker to go measure the blood pressure, give the home health education, train the government physician, set up triage counters within the government's clinics. And that was, again, and that intervention was developed, again, the foundation was our urban study, but then we also did a feasibility study in the 3 countries in the rural areas, assess the facilitators and barriers, and then we came up using the MRC model, a framework of final 5 components, and added the financing model to compensate for the additional services. We had to give the government community health worker about 20% of their salary for the additional tasks that we were assigning them. So then this is our 5-component, multi-component intervention compared to usual care. And so this was again a cluster RCT, and the clusters were again randomly selected. And this is such that this is not only stratified by country, we also stratified it by distance to the government clinic, so that such that we had some very far clusters and some near clusters, and they were equally distributed in the randomized group to ensure that we had an outreach even to people or to communities that were very, very far from any clinic. And so, and later we would assess the equity of the intervention. And so again, our outcome was change in systolic blood pressure. We followed them for 2 years. The red line here is a control. Blue line is the intervention. This is the primary outcome, systolic blood pressure. And we see the blood pressure declined in both groups, but the decline was much more significant in the intervention. Again, also for the diastolic. The difference was about 5 millimeters of mercury for systolic blood pressure. And again, it seemed to that over as the time went by, that was increasing. We observed an interaction with time, suggesting that the effect was becoming greater with the passage of time. We published in the New England Journal of Medicine, and all our collaborators, the key site PIs, thanks to all of them, are listed here. So it was a great team effort. We also assessed the per capita cost. So what is the affordability is what is the cost of rolling this intervention out to the policymaker or the health planner. So we assess so this is only the incremental cost of intervention, so which is cost per capita, and the incremental cost was just slightly over $1 per person annually in each of the 3 countries. So this is going to be a very affordable intervention to roll out. And then we did a cost effectiveness analysis, which assess, for value for money, and an intervention that is 3 times GDP, that averts 1 disability adjusted life year for 3 times GDP is considered cost effective. And 1 time GDP for averting DALI is very cost effective. So it was either cost effective or very cost effective in Sri Lanka, cost effective in the other 3 countries. So again, saying that this is very good value for money for the countries, and again, going to be very affordable. So I'll just summarize that the COBRA is among the first study demonstrating that a uniform, customizable community health worker led multi-component intervention is effective, cost-effective, scalable, potentially affordable solution, again, less than $2 per capita annually, which again qualifies to be a WHO Best Buy for controlling BP in rural South Asian communities. If scaled up, it's likely to translate into substantial reduction in premature deaths and disability, as well as gains in social and economic returns, which are aligned with the Sustainable Development Goals, which 3.4 says you reduce premature mortality. 3.8 is providing universal health care. And 1.0 is actually poverty alleviation, because you save premature lives. They're going to be more productive, and there's a health coming before economy. That's going to be, that's the way that is a way to poverty alleviation as well. Community health workers are an integral part of the primary care infrastructure for delivery of maternal child care in South Asia and many other countries where we believe that such a model can work, and it's rolled out. Other chronic conditions such as diabetes, kidney disease, and even mental health, we believe, could be targeted and evaluated using a similar platform. And finally, the model has implications for developed countries as well. Unfortunately, trends in blood pressure control in high-income countries have shown they are either no improvement or they're actually worsening in the last 5 years, especially in the US, they're worsening. There was a problem, there has been a problem with racial and ethnic minorities in the US with regard to CVD, CKD outcomes. And now there's clearly universal decline in blood pressure control. Now, several states in the US have introduced, either have or are introduced certified community health worker program into the public health programs. And I think, you know, a modified strategy using the community health workers adapted obviously to the local setting could be a way forward, especially for the South Asian community, perhaps with technology integration or elsewhere. So thank you so much for your time, and I'm happy to take any questions.
Thank you so much, Dr. Jafar, for an amazing talk. Now I'd like to open up our panel discussion. On our panel, we have Dr. Kinar Javeri, Dr. Nipur Upal, Dr. Amit Goval, Dr. Shuchi Anand, and myself. And I was going to throw out the first question. Dr. Javeri and I pretty much have the same question. So this is for any of our speakers, but maybe targeting Tazeen and Nisha. What strategies do you use when managing CKD in South Asian patients? Do you start an SGLT2 inhibitor sooner? Do you maximize RAS inhibition earlier in their disease process? Do you target more strict metrics like blood pressure and A1C?
Tazeen, feel free to start and I can jump in.
Well, that's a great question. I mean, I'm gonna try and not make this a long-winded response. But I think, the risks are higher of CKD, of the progression of kidney disease is accelerated, especially in diabetics. You already heard from, Nisha, you also heard from Alka about the enhanced risk, also of the premature beta cell failure, which also is telling us that there is going to be an accelerated, so the management is going to be a little bit different. So yes, we have to think about innovative approaches for South Asians, and they may be a little bit different. Regarding so without a doubt, ACE inhibitors, RAS blockage need to be started. The question that I'm going to just say here, unfortunately, and this is going to be a great platform to talk about this, the SGLT2 inhibitors, all the trials that have been done, there is very poor representation of South Asians. And there's no doubt that it's going to work, that it works. And this is a population, this is a very high risk population. And we've got 30% Asians, but they're mostly East Asians in the DAPA-CKD. So we do need more South Asians in the trials, but at any rate, the point here is that we need to be starting the SGLT2 inhibitors early. We need to be starting the ACE inhibitors early. We need to be controlling the blood pressure very well. Also in our CKD management, I think the focus and emphasis has always been on the drug rather than the blood pressure. And also the one thing that we do is based on where you're practicing is the glucose. And so, if you practice again in South Asia, you tend to keep a little bit higher glucose, glycated hemoglobin versus if you're practicing in the US. So there's a little bit of a difference, but again, for the risk of hypoglycemia and the management strategies with that. But I think other than that, everything you've got to be very aggressive.
Thank you so much. Our next question is from the audience, and it's directed towards Alka. If the question is, if someone knows that they have a tendency for relative insulin deficiency and have mild abnormalities on testing without frank diabetes, what is your typical advice to them? Do you offer specific dietary management advice?
Yeah, no, I mean, definitely. I think, even the diabetes prevention program that was done in India shows that you can do a lot in terms of delaying and preventing diabetes, but it's about catching it early, because the data we've seen in Indian studies as well as in Masala is the progression through pre-diabetes to diabetes is very accelerated. There's much more rapid movement out of pre-diabetes into diabetes when it is very hard to restore beta cell function. And I think I didn't show you any of our other data, but there's some evolutionary reasons that I think even children that are born with less beta cell function, and that's, we're starting with a half, basically not half the beta function, but a lot lower than it should be for a healthy infant. So yes, it's about early detection. It's about being really aggressive about prevention. And by prevention, I mean not medications. I mean going on, the best, absolutely best diet, which would be low carbohydrate diet. This is where I think really working with a nutritionist who understands South Asian foods and nutrition advice, and not talking about Mediterranean diet that no Indian will ever, or no South Asian will ever follow. Unless they're actually very westernized. So you have to, have the right resources to be able to talk to people about dietary changes that will work for them culturally. So diet, exercise, stress reduction, sleep, all these things that actually will help with both prevention of diabetes and reduction of blood pressure and prevention of CKD and prevention of dementia. There's all, it's all connected, right?
Thank you so much. Our next question is for Dr. Bansal, Nisha. This is from Dr. Goyal. He asks why, or he or she asks, why not think in terms of better classifying reasonable kidney health and use GFR estimate incorporating the Black coefficient for all races?
It's a great point. I think we're still trying to figure out what to do, but I agree that we should be using the same equation for everybody and thinking biologically. If there's a reason we don't trust the estimate, then we do direct a measurement of GFR. That's the approach I'm using now at our institution. I'm using the same GFR estimating equation for all my patients, and then thinking about reasons why I would not trust that estimate. But I agree, the ASN and NKF have a task force ongoing. They've released an interim report. So I'm hoping that there's some better conclusions that come out of that report to guide us.
Thank you so much. And I had a question for Dr. Jafar. Recently, the diagnosis of hypertensive nephrosclerosis has been called into question given the presence of genetic variants such as like APOL1. Have advancements has similar genetic advancements been made in South Asians to look for specific genotypes that can potentially contribute to genetic renal disease?
That's a great question, and I think that we absolutely need to study that. And I agree that there is a causality has been put into question whether hypertension is a cause or consequences. But that's one thing that we do know, and I think we keep on neglecting that. And then once there is the CKD, any degree of high blood pressure is going to accelerate that, right? So I think going back and saying, gee, we can relax a little bit and not de-emphasize the elevated blood pressure in terms of progression is perhaps the wrong approach, right?
Absolutely. And then along the same lines, do you have specific recommendations for which antihypertensive regimen you would choose in a South Asian person?
I think in a South Asian person, again, for people who have albuminuria, anytime is any degree of clinical proteinuria, go with a RAS blockade and, Losart, there's a cough issue and a cost issue. So you got to balance the two and where you're practicing. So I think the ARBs they work very well. And so, that's the one, you start with that. If a cough is, and, environmental pollution and all that is a major concern. So that's, any degree of, so that's what I would recommend. And of course, now is the SGLT2 inhibitors along with that. So any level, and again, be guided with the albuminuria. You see albuminuria, you put them on an ACE inhibitor, you also put them on a SGLT2 inhibitors. And do that early, regardless of the level of GFR, right? So even some people, even if you are in the hyperfiltration rate and you see a little bit of albuminuria, unfortunately, even in the US, there's a huge underutilization of ACE ARBs. Less than 50% of people who are eligible are on RAS blockade, so which is quite a shame. But we need to be more aggressive because this is South Asians are a high-risk population. So and they're off patent, right? So they're cheap.
Definitely. Dr. Jafar also had a question for Alka. Is there a higher mortality in the Masala South Asian group compared to other ethnicities?
Good question. We've only been following this group for now a total of median 9 years of follow-up, and they were age 40 to 84. So these people, I think you can say they're selected to be healthier than the average South Asian in the US because we only allowed people into the study if they hadn't already had a cardiovascular disease event, including any kind of, vascular procedures like angioplasty, stent, etc. So you can think of Masala and Mesa as being both kind of on the healthier end of normal for South Asians. So we are accumulating, as people are getting heart disease and strokes and dying. We've had 16 deaths so far in Masala, but it's too early to say that the rates are any higher or similar to any of the groups in Mesa. So we're gonna hopefully, if we continue to get funding, we'll be able to answer that question in another 10 to 15 years.
Those are the majority of the audience questions. I was wondering if our panelists have any questions that haven't been posted.
Hey, Tazeen, I had a question regarding barbers. Hijams in South Asia are very important. And in the African-American community, there was a study many years ago in NEJM showing that barbers had a big impact in blood pressure control. Any thoughts on using that as your community helpers in the South Asian community here and in South Asia?
That's a great question. And that kind of a model was actually evaluated in sub-Saharan Africa, one of the African countries first. And there, I think it was a very mixed effect. It worked better. And the study in the US, they had excellent linkage with the pharmacist. So, they come here, the medications are, unfortunately in South Asia, that connection with the pharmacies is not that robust. So again, we can have little pockets, but the question when we are developing a non-conventional model is maybe it can work in a smaller area, but how are you going to scale it up? And I think that is the problem that we are also facing with that kind of a model here in the US. Yeah, perhaps you can do this on a small level, but how are you going to be able to scale it up? Right. So I think that is the challenge. In South Asia, you don't even require prescriptions at many places, and there are going to be logistical issues. When we were trying the COBRA study, we actually wanted the community health workers to prescribe, to work like sort of a nurse practitioner kind of an approach that, can a physician supervise and they prescribe. And it didn't, there is a very strong physician lobby. And I think that is the case in India as well. So the entire South Asian region, that they are not going to be, they're not going to accept those kinds of models. where a non-physician is going to be prescribing even under the supervision. So that's especially for chronic diseases. Maybe they've done it for pneumonia where, one-time antibiotic is okay. But for any kind of chronic disease, unfortunately, is going to be a problem. And so, in the Barber study, there was a pharmacist doing this with them. So that kind of a model, I think it worked in that study. Scaling problem in the US, and I think going to be big issues.
Thank you. Thank you so much. This was an amazing discussion, and I definitely learned a lot. I was wondering if I think Kinar had a couple of words to say as we kind of wrap things up.
Yeah, thank you, Priya. I just wanted to thank Tazeen, Alka, and Nisha for the amazing discussion and the first of its kind series of talks we've had in the South Asian community. And I think it's very important that we get acquainted with these sort of discussions and studies out there to progress the science here. And a special shout out to our team here, Suchi, Nupur, Amit, and our MC Priya for doing an excellent job. And I think very well organized. And I really want to thank you all for your support, and Amit to get the sponsors, and the rest of you to getting everything organized in a timely fashion. And thank you for the audience for all the great questions and participating, and hope we all have a good evening, night, wherever you are. And thank you all.
Thank you so much. Thank you so much to all the speakers and ANIO and their sponsors. This was a very successful event. Thank you. And thank you for everybody who joined across the globe, and have a great night.
Thank you. Thanks so much.
Thank you guys for joining.
Thank you.